Sorry about that. So, as I was saying, palliative care education should be embedded into educational programs. Senior clinical leaders and academic professors should be confident and proficient with advanced care planning conversations, leading by example and teaching that palliative care should be a part of standard care. A couple of different ways nurses can be educated about palliative care would be to include palliative care education in undergraduate curricula. I know when I was in school, we'd never discussed palliative care. And so as education has evolved, this should be a topic that is embedded into the undergraduate curriculum. Also, we should ensure that palliative care is a focus of clinical placement. And as well to ensure that palliative care has appropriate representation within health boards and hospitals, in general practitioner education as well. So the second area of topic of this presentation will be hospice. And hospice has gone a remarkable transformation since it assumed its modern form in the late 1960s. It began as a movement driven by small organizations staffed with many volunteer providers, focusing on comprehensive spiritual, palliative, and mental health services for a relatively small number of terminally ill patients, typically suffering from cancer. The idea behind hospice during its early days was that a terminally ill patient and his or her family made a decision to focus on easing a patient's pain and anxiety, making him more comfortable, rather than pursuing additional curative treatment. Because these objectives required a wider range of professional and non-professional skills, hospice care involved not only physicians and nurses, but clergy, social workers, volunteer caretakers, homemakers, and, of course, the family. The process of decision-making by the patient and his or her family was never uniform and never systematically studied. Early experiments in hospice coverage noted that complex considerations at work during the hospice election process, including a patient's informed consent when he or she was in pain or heavily sedated, and the need to incorporate opinions from an attending physician, nurse, clergy member, social worker, and family member, among other constellations of participants. As a result, hospice care in the United States before 1983 was characterized by small providers who worked within the limits of prevailing institutional norms, tight budgets, and diverse approaches to the care of terminally ill patients. Matching terminally ill patients and their families with available and appropriate hospice providers was accomplished through the loose and undeveloped network of participating physicians, nurses, clergy, social workers, and volunteers who early on saw value in the alternative that hospice care provided. So hospice is more of a program that focuses on comfort rather than cure. Hospice is usually used in the later stages of a chronic illness, and it follows a multidisciplinary team approach. As previously stated, there are all kinds of disciplines that will be available to the patient. If you take a look here, you see at the very top is the patient. You is the patient. They're the center of everything that goes on. And then the team that is involved in the care for the patient includes the hospice nurse, friends, family, the medical director, and the physician for the patient, hospice volunteers, hospice chaplain, hospice social worker, and certified nursing assistants as well. So as you can see, palliative care has multiple team players, but hospice has more. Hospice is a broader umbrella, kind of, as far as how many people are involved. Hospice is a type of palliative care, so Not all palliative care is hospice. Hospice is more focused on the comfort of the end of life, but all hospice is palliative, meaning it's focused on comfort. Hospice now is changed a lot from years and years ago. So now hospice is one of the fastest growing costs of Medicare, which began covering hospice in 1983. According to the National Hospice and Palliative Care Organization, the number of people using hospice increased from 495,000 people in 1997 to 1.3 million people in 2006, an increase of 162% in only 10 years. While cancer remains the top diagnosis among hospice enrollments, its percentage is decreasing as more patients are referred to hospice with diagnoses like Alzheimer's, dementia, and failure to thrive. Between 2002 and 2008, 4 in 10 Medicare patients died while under the care of a hospice provider. For its proponents, this trend makes sense. Hospice is a compassionate, humane alternative to the toxic, painful, dehumanizing aspects of curative medicine, especially as it is applied to patients suffering from particularly painful terminal illnesses. One example I mentioned is cancer patients. Typically when you think of hospice, you think of patients who have cancer. There's been a lot of talk about oncologists, wanting to do whatever they can for patients, radiation, chemo, treatment. We all know sometimes treatment does more harm than good, and getting someone on hospice is sometimes just a matter of getting the patient to the right point in their life. They have to be able to accept what's happening. Not everyone's ready to give up hope. A lot of people think that that's what hospice is that it's the last resort. I'm giving up hope, and things are going to end. And so that's why, like earlier we talked about palliative care sometimes being too little too late. The same goes with hospice. Sometimes most of the time patients don't get all of the benefits of hospice because they don't accept it until too late in the process. And so educating nurses and other healthcare professionals on what hospice is and what hospice does will hopefully allow patients to reap the benefits much more. So when is hospice appropriate? Each hospice has its own policy. There's hospice agencies all across the country. I know the institution I work at, we have our own hospice agency, and in the community there's at least maybe 3 to 4 other competing hospice agencies, and everyone has their own policies. But Medicare requires 6 months or less life expectancy for certification of eligibility and reimbursement. Other important criteria include patient and family understanding and wishes. Evidence-based guidelines for determining prognosis in some non-cancer diseases have been developed. However, despite their widespread use, limited data exists to support their accuracy. Moreover, a high degree of prognostic accuracy may be unattainable given the unpredictable course of common non-cancer chronic diseases. Hospice eligibility for patients with non-malignant disease is based on clinical judgment. Hospice referral with a non-malignant disease or diagnosis is challenging, but essential to quality patient care. Between episodes of disease exacerbations, healthcare professionals need to take an active role in discussing goals of care, remembering that some patients and families need permission to change to palliative goals, rather than continuing with aggressive interventions. The time to refer to hospice is when the goals of care become focused on quality of life and staying out of the hospital, rather than intervention in the disease course. Most patients underuse the benefits that a hospice referral can provide. And while some patients outlive the 6-month criteria for hospice care, this benefit can be renewed if the patient still meets the criteria. So, It's important to understand what diagnoses will qualify a patient for hospice, and this is something that is strictly Medicare driven. Most cancers are going to qualify a patient for hospice because without treatment, remember, hospice is not treatment, it's not focused on cure, it's focused on comfort. Without treating a cancer, typically a patient would expect to live 6 months or less. Not always. There's other diseases that will qualify a patient for hospice. A patient with Mycobacterium avium, without treatment, they could expect to live 6 months or less. CHF, aspiration pneumonia, sometimes from having a stroke. If you're not going to treat the aspiration pneumonia with anything, then that patient could expect to live 6 months or less. Sometimes it takes a doctor writing out a clinical picture of the patient that explains exactly why the comorbidities the patient is experiencing would lead someone to expect them to live 6 months or less. It's not cut and dry, it's not black and white. There's been a lot of Medicare fraud done from hospice agencies, and that's why Medicare is so strict on the rules and regulations, because they don't want fraud to be committed. But it's up to us as nurses and healthcare professionals to advocate for our patients and make sure that they get all the benefits of a hospice referral, and they possibly can. So lastly, we're going to talk about advanced care planning. And advanced care planning is used in both palliative care and hospice. Advanced care planning is the process by which individuals may ensure that their health care preferences are respected at the end of their lives. Written and verbal instructions, and usually are called advanced directives, and they are intended to make sure that individual healthcare choices are communicated and instituted. According to the Agency for Healthcare Research and Quality, only 20 to 30% of all Americans have an advanced directive. Fewer than half of severely or terminally ill patients have an advanced directive. Primary care providers and physicians should address advanced care planning with their patients, preferably before a medical crisis occurs. And it's important to remember anyone at any age can complete advanced care planning. Advanced care planning is something we're seeing a lot more of in the medical field. We're seeing it in the inpatient setting and the outpatient setting. Physicians will start being reimbursed for this from Medicare. It's an important tool to use to discuss patients' goals of care. The only one of the drawbacks is that a healthy young 50-year-old doesn't always want to talk about what's going to happen at the end of their life. It's hard to imagine where you're going to be on your deathbed. You don't know what will happen. We could play out scenario after scenario. We could say, well, if you're in a car accident and you're on a ventilator and you're brain dead and you have no chance of returning back to your baseline functioning, we could play those scenarios out, but until someone actually lives through that, it's really hard to picture what they're going to want. So it's a difficult process, but with education, I think we can get there. We can educate nurses, healthcare professionals, and patients on the importance of this important tool. So the advanced care planning discussion record is important. What it involves is, as you can see the image on the right, advanced care planning is an umbrella that encompasses the advanced directive and the POLST form. These are two documents that are used in advanced care planning. What the advanced directive is, as kind of previously mentioned, it's a legal document that healthcare providers use to help a patient to distinguish who they'll choose to make life and death situations or decisions for them when they're not able to do so themselves. So if a patient's in a medically induced coma, or they're not lucid, they have dementia, They cannot make their own medical decisions. The advance directive healthcare power of attorney is important to distinguish a proxy. The POLST form is the practitioner's order for life-sustaining treatment. This is the form that will designate whether a patient is a DNR or a full code. These forms are difficult, they're tricky, they're very complicated because it's got medical jargon, there's different levels of care. If a patient wishes to be a full code, you know, I always say, if you're found without a pulse and you're not breathing, do you want us to do everything we can do to bring you back? The patient says automatically, yes, do whatever you can. You know that they want to be a full code. It's over. It's done. Just, you know, leave it at that. The form does not need to be completed. But if they say, no, if I'm dead, don't do anything to bring me back, then we have to move on to the second part of this discussion in this form, and that's being a DNR. So if you're found without a pulse, you're not breathing, we're not going to do any compressions, we're not going to do resuscitative measures. But leading up to that point, there are different levels of care the patient can choose, and these levels of care are so confusing. They're so overwhelming to the patient because there are 3 levels of treatment. The first level is comfort-based treatment, then there's selective, and then there's full treatment. And comfort-based treatment means, you know, let nature take its course. If I am deteriorating, my health is declining rapidly, I don't want interventions. I want comfort. I want medications to relieve pain, to relieve suffering. Let me go. The second level is selective treatment. This is the most common one chosen among patients, and this just says, do everything, but do not intubate me. Usually in this discussion, when you talk about a breathing tube, patients will either say absolutely yes or absolutely no. And if you can distinguish whether or not they want intubation, you can pretty much steer them in the right direction. If they do not want to be intubated, they are going to be a DNR, selective treatment, which means we'll give you oxygen, we'll put you on a BiPAP, we'll give you pressors, we will give you antibiotics, fluids, whatever we can do, but we're not going to intubate you. And lastly is the full treatment DNR, which some people think is odd, strange. If you're a DNR, why would we intubate you? But in full treatment, we are going to do everything we can possible to prevent a cardiac arrest. These POLST forms now are not necessary to be done. A doctor just needs to order, you know, the level of intervention for the hospital setting. But for the outpatient setting, this is where the POLST form becomes important, because if you're in the hospital and the doctor orders DNR limited, we're not going to intubate you, but you don't complete the form and you leave the hospital and you code, well, someone's going to find you and code you and intubate you. So it's important to have these discussions with patients from the beginning. Nurses need to know how to have these conversations with patients so that we know what their wishes are. The discussion record is a tool used to help the patient understand the purpose of advanced care planning. We will ask the patient, do you understand the purpose of having an advanced care planning discussion, and naming an agent who will be able to make decisions that you would want if you can't speak for yourself. That's the number one statement we start out with. And then we go into, you know, what gives you meaning in life, or meaning and happiness in life. Family, friends, work, pets, you know, whatever gives you happiness and joy. We want to talk about that. And then we want to talk about what keeps you going during difficult times. You know, do you turn to family? Do you turn to friends or prayer or Bible readings or your faith? How important are these things to you? Then we'll talk about spiritual care. You know, what kind of spiritual care would be meaningful to you at the end of your life? Do you not want spiritual care? Do you want prayer? Do you want Bible readings, hymns, songs, communion, anointing of the sick? This is important. You know, some people, their faith's not important to them. Some people are Catholic and they want anointing of the sick and they want communion. Some people are a different denomination of faith and they have different rituals that are important to them. And it's up to us to know what those rituals and preferences are, so that we can honor their wishes. We ask them, who would you want around you during the last days of your life? Do you want everyone you've ever known to come at your bedside if you're dying? Do you want just immediate family? Do you want privacy? Do you want extended family? You want friends? Who do you want around you? We ask, are there any relationships that you would want to restore before you die? Sometimes patients are struggling with an estranged child or a loved one who they've had a falling out with, and that really weighs heavy on their heart. And sometimes we all know patients making amends can really ease their soul and make the dying process a lot easier. So we want to make sure we identify anyone who they maybe want to make amends with. It won't happen at that point in time, but if we can identify it, that's at least something we can help them work towards. If given the option, we ask them, where would you prefer to die? Not everyone wants to die at home. Sometimes dying at home puts maybe a spouse or a loved one in a very uncomfortable position after the death. A lot of memories, my husband died in the living room, and if you can't look at the living room in the same way ever again, or then you don't want to move. There's all these different thoughts tied up into that situation. So sometimes a family member would prefer if they would die maybe in the hospital with staff around them, because they can be cared for by appropriate staff. That burden, that caregiver burden is gone, or a hospice home or a nursing home. Pain control is a big discussion because not everyone responds to pain the same way. We want to know, if you're in severe pain when you're dying, what kind of pain control do you prefer? Do you want complete pain control where you are not awake, you're not able to communicate, but you are not in pain? Or do you want moderate pain control where you're awake, sometimes, but you're mostly not awake? Maybe you want mild pain control where you are always awake, but you can feel some pain. It's not intolerable, but it's there. Or maybe you don't want pain treatment. You just don't want anything. These are important for us to know because they will help to gauge the patient's plan of care when the time comes. Lastly, we want to talk about the wishes a patient has for their body. Do you want organ donation? And a lot of patients will say, oh no, I'm too sick. No one will want anything that I have. And it's important for them to know that's not their decision. Gift of hope will be called when you pass, and they will determine whether or not you have any organs that are able to be harvested. It's just your decision if you want to even have that attempted. Maybe they want autopsy, maybe they want cremation. We don't know. We just want to know what their thoughts are, what their wishes are. The whole goal of this discussion record is, it's not a legal document by any means, so I'll tell patients, whatever you say can be changed. This is not set in stone, but it helps your family to understand what you want when the time comes, because when you're on your deathbed, there's been a crisis. This is not the time for people to guess about what their loved ones want. They would rather know that we've talked about it, we put some thought into this, and we know that this is what should be done. Now, another area of advanced care planning in the discussion talks about the late stages of treatment, or the late stages of a disease, and what kind of treatment the patient would want. If they have heart failure, do they want a defibrillator? Do they want frequent hospitalizations for complications? Do they want dialysis? If they have Alzheimer's disease, do they want a feeding tube? Do they want to be placed on a ventilator? Some of these things we need to think about. But it's always hard to put yourself in that situation when you have not really ever thought about it before. When you're a healthy individual, it's hard to think about, well, what happens if I have dementia? What would I want? If they've seen a loved one struggle with those things before, sometimes it puts it in perspective for them, and it's easier for them to say, yes, I want this, and no, I don't want this. So the importance of advanced directives is extremely crucial today in healthcare, especially just to take the burden off some of our caregivers. Self-determination and autonomous healthcare decisions are respected by the American public, and they're integrated in medical professional ethics. Patients can make their own decisions unless they are deemed medically incompetent. Medical incompetency is generally defined as the lack of capacity to determine medical information and clearly communicate decisions. Advanced directives completed prior to the time that a patient who is medically incompetent will be used to direct the healthcare proxy or guardian in medical decision making. However, when the patient is deemed medically incompetent, a guardian should be provided by the court system at the time of application to the court, unless there is already a healthcare proxy identified by a legal document. So, up until the time a patient is unable to make decisions for themselves, what they say goes. We may not like it. We may think it's ridiculous. We may think they are totally not getting it. But if they're competent, their decision must stand. Now, if they're medically incompetent, there is a surrogacy process that must be followed by law. So say there's a 60-year-old woman who is medically incompetent. She has a husband. He is automatically a surrogate. A spouse is number one surrogate. If there's no spouse, it falls to adult children. If there are no adult children, it falls to other adult family members. There is a process to figure out who would speak up for a patient, but the importance of having the advanced directive, the healthcare power of attorney, is, say there's a family squabbling and there are some hurt feelings in the family, and there's people you don't want making decisions for yourself. Well, unless you complete the forms, that may become a reality. And that's what patients need to understand, is that while you're able to make your own decisions and make your wishes known, you need to do so that when you're not able to, we can act on your best interest. And palliative care programs and hospice programs both use the advanced directives, the advanced care planning process, to make the wishes and the goals of the patients become a reality. So, in conclusion, the population of chronically ill patients is definitely growing. Nurses need to be aware of the services that are available to these chronically ill patients. Palliative care and hospice consults should be ordered appropriately. They should be identified immediately. Nurses don't have to actually make the consult all the time, but they should maybe be thinking about it. They should bring it up maybe to a provider or to the palliative care team or to a case manager or a care manager, and maybe just say, I think so-and-so would really benefit from palliative care. They've had multiple readmissions. They don't seem to quite understand their prognosis. They have a lot of comorbidities and their care is complicated. Maybe they could use an extra layer of treatment, an extra layer of care, or hospice. They have been diagnosed with a terminal disease and they're not really sure how to cope with that, and they're not sure they want to undergo treatment. So maybe we should have our hospice team get involved and talk with them about the options that they have. And lastly, advanced care planning can be used as an added resource. Advanced care planning does take time. It takes about an hour to go through all of these things. It's not a light discussion to have. It shouldn't be, just gone through quickly. It should be talked about with a lot of thought involved in the discussion. The healthcare provider leading the discussion should be fully engaged with the patient, and these discussions should be meaningful and worthwhile. And any patient at any age can do this. And it may change over time. You may do an advanced care planning session when you're 35. And maybe 10 years later, it's changed. Maybe you've seen someone pass in a certain way, and you say, I want to change my thoughts on this. So things can always change, but it's just important to have the conversation, just to start the discussion. Sometimes is what's needed. So how can we evaluate learning that's been done with nurses and healthcare professionals? Discussion groups with nurses can be greatly beneficial. Nurses sometimes think in different ways. Some understand some things better than others. So maybe getting nurses together in groups to talk about their experiences, to talk about the patients they've seen, and they can say, "Yeah, I saw this patient and I referred them to palliative care for X, Y, and Z." And someone may not understand why, but then they may say, "Oh yeah, I can see, that was your thought process, and maybe my patient over here that I have could benefit from palliative care as well." They'll definitely be able to learn from each other's experiences. Monitoring the number of referrals that palliative care and hospice are getting as education is done more and more in the healthcare setting, these referrals should grow. We should get more referrals. They may not always be appropriate, but at least they'll be referrals. It's up to the palliative care team to really sift through that patient's chart and say, no, they're not appropriate, or yes, they are appropriate. Same with hospice. But at least we can make a referral and get the conversation started. That's the important thing. And monitor the number of advanced care planning sessions. Nurses are not going to be the ones doing these sessions. I mean, they take too much time for a bedside nurse or an office nurse to be doing with patients, but we do have advanced care planning facilitators throughout the OSF ministry, and so we're trained to do advanced care planning. But if nurses can help to distinguish a patient who is in need of one, or maybe even explain it to the patients so that they better understand it, then we should see our numbers definitely grow and increase. So I thank you for your time listening to my presentation on how to manage chronically ill patients. I really hope that you've taken away the key learning objectives of how to define hospice and palliative care, how to make those referrals, which patients are going to benefit from those programs, and then advanced care planning, what advanced care planning is, what it can do, the goal of it, the benefit of it. I hope you can take these key learning points away and use them in your everyday life. I appreciate your time, and thank you.